We're here with Dr. Holly Geyer. We so appreciate you being here, an addiction expert, also author of Ending the Crisis, the Mayo Clinic's Guide to Opioid Addiction and Safe Opioid Use. And today's topic is really important. It's the issue of what to expect in addiction treatment. And I know from experience in this area with my family that honestly we didn't know what to look for, we didn't know what to expect, and so it was really difficult for us to understand, especially at the beginning. What do we do? What are those elements of quality care? How do we know where to go? So I really want to talk to you a little bit about these core elements of addiction treatment, what to look for in a treatment program, because there's plenty of information we could talk about here, but let's just start about, that basic question. Is there one right way to treatment addiction?
You're asking a loaded question, Kim. I would say in short, yes and no. There is no one right way to treat addiction, but in general, there is one right philosophy on how to treat it. And that philosophy is one that addresses the patient as a whole from a biological and a psychological and a social and a spiritual standpoint, all the domains that make us human, right? This is known as the biopsychosocial spiritual treatment paradigm.
So in other segments that we've talked to you about issues like how the brain operates and essentially the rewiring, is one of the problems we have. So why wouldn't we just target the biology in our treatment strategies if that's really the main issue?
Legitimate question, and we're seeing that emerge as a prevalent philosophy in society. But I want to take us back to the American Society of Addiction Medicine definition of addiction. So they call addiction a primary chronic disease of brain, reward, motivation, memory, and related circuitry, exactly to your point. But that dysfunction in these circuits is going to lead to the characteristic biological, psychological, social, and spiritual manifestations. And then all of this is going to be reflected in individuals pathologically pursuing reward and or relief by substance use or other behaviors. So in short, even though it's driven by that biological domain, it's expressed in all the others.
So have there been any studies that kind of show, really what's happening here so that we can understand it better?
There was a fascinating study, in fact, a couple of them that were done in China. We know the part of the brain that really seems to drive addiction, and so they took a number of individuals and they cut that part of the brain out. What they found, though, was fascinating to the addiction community, because without the brain now having this problem of the chemicals transmitting in the directions they shouldn't go, we assumed there'd be a cure, and we saw that cure in half the participants. But what's going on in the other half, right? Why didn't the other 50% respond? And what we identified is that it's not just the pathological pursuit of reward that's going on in the brain, it's all of the behaviors that come with it. It's the hurtful things that we said when we called our husbands or wives when we were drunk, right? It's the 3 WIs that are waiting for us to get processed in the county courthouse. It's finding that person's very purpose in life or the memories of severe childhood sexual trauma that are the drivers for ongoing activity and behaviors. The reality is that the brain adapts to a new drug in our system, and then the life adapts to the new brain in the system. And that brain is made up of all these domains, the biological, the psychological, the social, and the spiritual domains that manifest in life. We're really complex creatures, Kim. That's going to lead to a complex existence, and each of our lives is impacted by others.
So when we're looking at a comprehensive, treatment approach, that seems to make sense to me. So why don't we break down, that bio-psychosocial spiritual philosophy, begin with the bio. So I assume this means biological.
You got it. Yep. The biological realm is really talking about our physical health and the changes, of course, biologically that come with addiction. Examples of addressing the biological realm would be things like using buprenorphine or methadone in opioid use disorder to replace those missing brain chemicals, using antidepressants because the drugs have reduced the normal levels of those healthy neurotransmitters that we should have and that we should naturally be making. or addressing the health consequences of addiction. You know, people that have infections from needle use or breathing problems due to snorting or ingesting in unhealthy ways. There are many people who pursue treatments that omit this incredibly important part of their treatment paradigm, and clinical studies show, in most cases, that results can be fairly dismal, if not dangerous.
And in other sections, we talk more specific about, medically assisted treatment and which, medications are being used, how to effectively use them. So we're not getting into those details today, but we are talking about the fact that there's a biological issue here that needs to be addressed. So as we see that, maybe you could talk a little bit more about this, especially from the issue of opioids.
Yeah, opioid use disorder is a great example of the power of addressing the biological component in the whole continuum of care planning. We've identified that 85% of people will be back on opioids in the setting of opioid use disorder within 1 year, frequently within 1 month, if they aren't started on medications for opioid use disorder, this being typically either buprenorphine or methadone. Other conditions like alcohol use disorder can result in people leading lives that are just a relapse after relapse, and use of medications like naltrexone can greatly reduce those relapse events. Some people who initiate drug use for underlying mental health problems, an example would be depression or bipolar disorder, they're going to stay high risk for relapse if we're not addressing that underlying disorder and helping with those neurotransmitters that are aberrantly firing or not firing through the system. And so for all these reasons, I think it's absolutely essential that we ask the treatment program that a person's looking into whether they address biological issues with medications that help bridge that person towards recovery.
And again, we talk about these in more detail in other sections, but for the sake of this conversation right now, one of the most important things I think to understand is we're not talking about how long these are used. We're not talking about which ones are more effective than others. We're simply talking about the fact that in some cases, in most cases, having some medication to assist is going to be helpful.
I think you're absolutely right. And it's difficult, I think, for most people to understand the concept of using medications that can oftentimes in themselves be considered addictive substances to help treat addictive substances. What we've recognized is that when we're doing that approach, what we're actually doing is filling a chemical deficit that the body is no longer actually producing or to a degree necessary because the drugs of abuse have shut it down. Again, examples, medications for opioid use disorder or antidepressants.
So again, just to kind of wrap that up, the idea is to use something to help get to the point where we can deal with it from the other aspects that we're about to talk about.
In essence, and in most situations.
So, a lot of people, have serious concerns about this whole medical model of addiction, even to the point of not believing that it's, really a disease. As a matter of fact, I hear that pretty regularly. It's just a choice. And so for many people, they look at medications or these other issues that you just talked about as far as dealing with it from a biological standpoint as being an unnecessary. That's just a crutch. That's going to compromise this whole thinking about how to deal with this. And so these drugs, in particular, like buprenorphine or Suboxone, most people refer to it as, these are drugs that can be abused themselves. So again, going back to frame the value of using something like that, and I'm assuming you don't mean in every single case, but you mean on a regular basis.
I think you've really gone into one of the biggest reasons that people oftentimes choose not to seek out treatment with medications, and it's most often to their deficit, especially in opioid use disorder. We've talked about that number, but the majority of people who aren't getting those medicines won't be able to engage in other forms of treatment. And, we recognize there is value to finding that balance between that biopsychosocial spiritual approach becoming more so a transition in life to focusing on the psychosocial aspects as people are able to engage with those aspects of treatment over time. But again, if your brain's not allowing you to function, to think clearly, to not think about cravings or experience withdrawal symptoms while you're trying to sit through seminars or lectures or talks or group therapy sessions, then it's really pointless to try and engage with them at all in many cases. And, I think it's important to think about other pathways too. Sometimes we use these biological approaches to block part of the brain that drive cravings. An example would be naltrexone. Or to induce symptoms if the drug is taken, like dilsuphiram, both of which would be good examples in alcohol use disorder. When we go back to the concept of replacing one drug for another, which tends to be one of the biggest frustrations with the medical model, I oftentimes give the example of the donut, right? So let's take a person who's experienced a massive 4-vessel heart problem, and they just about coded on the table, and the cardiologist was able to bring him back to life, and the cardiologist said, listen, you eat way too many donuts. I've heard that you eat a donut or 2 or 3 a day, and it's going to kill you. I've got a solution. I'm going to give you a donut every day. But keep in mind, this donut is going to be carefully crafted, not to give you that super high, but enough to curb cravings. It's going to be formulated to prevent you from feeling that deep sense of loss or hunger when you don't have other donuts in your system. We're going to have a scheduled regimen of when you get that donut, so it's going to provide some structure in your life. We're going to have regular contact with your care team, because the only way you're going to get this donut is to come to my office so we can check in with you. We're going to check you and do urine drug screens for other donuts of abuse. And then we're recognizing that there is a minimal risk of side effects with this donut in clinical studies, and that we're also going to require you to go to psychological and spiritual and social events to make sure that those aspects of overeating other donuts have been addressed. It would be a paradigm shift, right? But then again, what if the data supported that? Right? The reality is that there's opportunity to look at this from a holistic model of integrating all other forms of care when we address some of the basic drivers so that the brain is able to think through things clearly. That's really what we're getting at with the heart of the biological model, Kim.
So really, when you look at it from that perspective, you don't look at it as just simply trading, one drug for another. It's not the idea that I'm just going to give you something and then that's it.
Bingo.
Because our goal is that we want this person's life to be restored. We want this person to get back the life that we had hoped for them. And especially when you have a loved one, you want that life for them that that they could have had. And so, sometimes we've heard about scenarios where even these treatments are abused. And so maybe you could talk just a little bit about that as well.
I get it. There are concerns, and the general public is correct. In some situations, the treatments that we offer, especially for opioid use disorder, can be abused in themselves. I can tell you, we in the provider field work very hard to minimize this, and it's why it's key that if they're integrated, it's individualized to the person, they're monitored closely, and then that we review the value of these drugs regularly. Benefits should also and always outweigh risks. The data shows that in many, if not most situations, people are abusing these drugs because they're underdosed or inappropriately dosed. We often see very aggressive monitoring of protocols that are used to make sure that these drugs aren't misused, not being diverted. That includes pill counts or direct administration or frequent urine drug screens. And when we do see the misuse, especially if it's diverted, it's addressed. If we identify that oftentimes it's time to switch drugs or treatment environments or look for any other drivers that we may not have addressed.
So maybe you could just explain the goal of using these drugs and what we're actually targeting.
2 words: abstinence and recovery. And I'll say them again: abstinence and recovery. It's about giving them their lives back and keeping them away from harmful drugs. And keep in mind that virtually every clinical evaluation is an opportunity to look at the risk-benefit ratio of what we're giving them. If the drug is making the patient more functional, if it's allowing them to engage in other forms of treatment, If it keeps them away from illegal activities or prevents them from acquiring other diseases that could sometimes be associated with drug use, if overall they're moving towards recovery, there's a really good chance that this is a good option for them. Remember though, abstinence is not recovery. Abstinence is not recovery, and abstinence is what we're going to achieve when we put these people on that drug, really the state of not using other harmful substances. But again, we've talked about this in some of the other discussions. That is not getting your life back, is it? This just allows for the platform for you to now build on. For some people, we've recognized that over time these medications can be titrated down or discontinued. In others, especially those with a history of recurrent relapse or very high-risk drug behaviors with polysubstance abuse or very poor living circumstances, there might be significant benefit to keep them on longer. And so that's why it's key that we as providers are individualizing and tailoring.
So trying not to get into this debate over the idea of abstinence versus, what does that really mean? I think what you're saying is that if we can keep them from what was really causing the harm, hopefully we get them to the point where they're actually being able to engage and hopefully address all those other issues. And from a personal standpoint, hopefully at some point, they're getting to where we don't see them needing medication. I mean, isn't that really sort of the goal in most things when it comes to treating people from a medical standpoint?
It oftentimes is. When lifestyle changes, when decisions are made differently, all contribute to the way that person acts on a daily basis and makes their decisions. Oftentimes medications aren't needed. We sometimes see this for people who eat much healthier and then are able to eliminate their need for medications for diabetes. There's other patients that simply can't make those changes in life and become dependent on the drug. So again, it's really about individualizing it and then using every tool at our disposal to help that person achieve full recovery.
So if we look at this from the perspective of each individual, and I think you brought it up, but it really does need to be something that acknowledges the views of the patient on this topic, to kind of work through it.
This is not a one-man show. Our industry has learned the hard way. Studies show that many of these people taking the drugs just don't feel normal. For medications like buprenorphine and methadone, they may not think as clearly as when they did when they were off the drug, and studies actually prove that. I've heard families comment that their loved one is, quote, a zombie, or that they might as well have been on the other hardcore drugs. These are disturbing comments for our industry, and again, these situations can be very difficult to navigate. It's going to take a risk versus benefit review. The first step, I think, for us as clinicians is to relook at the factors that we can mitigate. Is it the right drug? Is it the right dose? Let's start with fixing those. And then if these issues are already optimized, then we really need to look at the factors such as the relapse history of that person and their progress with other forms of treatment and their living circumstance, and the number of other substances they were using as to whether or not the benefits of taking them off it outweigh the risks.
Again, when we have somebody that's, saying that, they don't feel like themselves. My son, made those comments to me, when he was using some of these medications. And it was tough because he just didn't feel right. So could you talk just a little bit more about, as a provider, how you, approach that patient that comes in and acknowledges that to you?
Yeah, we could treat patients very differently based on their history when they come to us and they say, I'm ready to come off the drug. An example I would use is a patient who's maybe been on buprenorphine for opioid use disorder for 1.5 years. They've completed a treatment program successfully. They've had no relapses. They've got stable living environments and a good job. That might be a great person to think, sooner than later, let's see if there's opportunity to try and taper. If they wanted to. Another example might be a person who's been on buprenorphine for 1.5 years. They've relapsed 3 times. They've had challenges at home and at work. They've been kicked out of the house twice. If this person relapses, there's a really good chance, Kim, that they're going to turn to fentanyl. And if they turn to fentanyl and they have lost their tolerance to previous doses taken, they are minutes away from an overdose. So, in both of these scenarios, what we're really balancing is how they feel with how they're likely to actually survive based on their relapse risk. In the world of deadly fentanyl, we have so little wiggle room to get this decision wrong. And this is why we see clinicians oftentimes steering more towards longer is better. The clinical studies oftentimes support this approach, but again, patient or client ideals and goals absolutely need to be taken into consideration too.
So maybe we could just switch topics a little bit and talk about the psych part of the biopsychosocial part of this. So what does that psych part really refer to?
Yeah, so psych is referring to psychological. It's the part of the treatment plan that really deals with the mental health contributors to the addiction. We know that in addiction, mental health problems can be either an initial driver for use or actually result from it. Think about PTSD or depression or severe anxiety or bipolar disorder or schizophrenia. All of these as baseline conditions can be drivers, and we should be treating them. If we do, addiction outcomes improve. If we ignore them, we're just going to increase that person's risk for relapse. But it's also the part of the treatment plan with dealing with how we think about ourselves, our relationships, and our problems, our past, our future, and really help us build out those healthy thinking patterns and coping skills that we're going to need to achieve recovery.
When we treat them with this, psychological part of it, we're hoping for better outcomes.
You nailed it. I think it might be good to kind of think about the different kinds that are available. I'd start probably with the most common type, counseling. There are many different forms of counseling that a person might encounter over the course of addiction treatment. Drug and alcohol counseling is very common, but there's also group therapy sessions, family counseling, individual counseling. They all work really off the same premise, though. Identify thinking patterns that set a person up for failure and help them make rational decisions. They can also help people work through painful memories that might be triggers for relapse. I find it fascinating because the science behind counseling is just an amazing field of science. When it's done well, we can actually see changes in how the brain parts talk to each other before and after on imaging techniques. It's really a good way to help rewire that brain back into the correct structure and then turn those 6-lane freeways of connectivity between parts of the brains that shouldn't be connecting back into the bike paths where they were before.
So maybe you could talk just a little bit about those different types of counseling, because we hear about the different ones like group and individual and family and all of that.
Yeah, when we think about addiction, group counseling is probably one of the more common ones that people are familiar with. It's got a unique approach. It uses this positive social pressure of everyone sitting around telling each other stories to emphasize the treatment concepts and then ultimately promote that drug-free lifestyle. This is in contrast to individual counseling, which is a very personalized approach, and it really helps get to the heart of the issues and the initial reasons for use oftentimes. I think family counseling is key. Again, we've talked in other discussions about the dynamics changing in a household, and those can be terrible triggers for relapse if they exist and haven't been dealt with by the time that person's really brought back to the house. Family counseling helps pull all of those relationships and issues on the table and then offer this non-threatening, organized environment to expose what can be honest thoughts and then set expectations too. There are also different ways that counseling can be done. I find motivational interviewing to be one of the best ways in the setting of addiction and has some great data. Instead of having that counselor just simply offer the advice, the technique actually reflects a process of involving open-ended questions for that person, having them build on their own personal, rational thoughts about a topic, and then reflecting on their responses to come to their own decisions. Cognitive behavioral therapy is another common way this is approached. It's a more traditional approach of having an open dialogue and helping change how a problem is viewed with counselor support.
So I also know that a lot of treatment programs, they employ non-licensed counselors. I know there's a lot of ways to get the training for this, but is licensure really make a difference?
Kim, I've got kids. I know there's a lot of ways to learn how to drive a car. Does having a license make an impact on teenage drivers on our roads? Do you feel any better when non-licensed teenage drivers are out there? You better believe it, right? They've learned the machine that they're driving when they have that little certification. They've had the right amount of practice to repeat safe driving behaviors predictably. A third party certified that they're capable of doing this activity. And importantly, the rules that they agreed to for practice follow those that are best scientifically validated and really industry sponsored. Kim, I've watched my 5-year-old drive her Power Wheels. Obviously it makes for great YouTube videos and keeps the Band-Aid industry in business. But heaven help all of us if she makes it out of the driveway. The reality is that the behavioral health field is truly a field of science. I want to reemphasize that. And the principles that come with licensed counseling services are grounded in evidence-based tools. People that undergo licensure, they are mental health professionals, they are specialists, they are brain rewiring technicians, in my opinion, and the tools they use in conversations to help us to get to think correctly come with a wealth of clinical evidence behind them. The homework they give us is grounded in proof that it works. So if you're going to follow the science, I would say go to someone with a stamp of approval to offer it, and that's the licensed industry.
Well, as we move through this, the biopsychosocial, we're now kind of at that social part of it, of drug treatment. So this one sounds a little bit more self-explanatory, but maybe you could just go into that a little bit.
No, it definitely is. It refers to addressing how the person struggling with addiction operates in society. If you think about the more severe cases of addiction, that person may have been kicked out of their house and now they're homeless, or they've lost custody of their kids, or they've lost their medical insurance, or they've got 1 million misdemeanors for theft, or they have no form of transportation or no formal vocation, and they're going to be starving. In these examples, tell me why drug use wouldn't be appealing to people struggling with this, right? It's a reality most of us would want to escape. Why wouldn't they? And the data shows that if these needs aren't addressed, relapse risks are very high.
So again, being involved, being engaged from a social aspect is important.
This is why it's key to get engaged with a treatment program that addresses those social issues. I would say in many cases it's becoming the industry norm, which is wonderful. Many programs can help with vocational training or placement. They can help with travel to and from the program. They can set you up with community legal services and arrange housing. We're seeing an evolution in this world as it relates to drug and alcohol counseling, assisting with this approach as well. So we're finally heading in the right direction, I would say.
And as you see that, and you see many of them, offering these services in addition to the bio and the psychological part of it, these social issues can be very important. And it seems like that's what's going to really help them when they want to integrate back into society.
Yeah, you're absolutely right. We know many of these issues can be dealt with concurrently during treatment, but I would say they're most needed during the time frame when that person's going back into the community at the end of treatment, that transition time frame. The services offered at the end of treatment and afterwards are called aftercare. The amount of aftercare offered varies dramatically. It's by treatment program, by insurance coverage, all sorts of factors. And it's definitely a program feature worth asking about when you're looking into a program. For certain, you're going to want to ask if that program helps develop a relapse action plan. I would say that's your number one priority. And then, also check into what treatment options they offer should a relapse occur. Do they have direct admission policies back into the program? Do they require reassessments? What's the time frame to get someone in? You'll also want to know whether that program will stay in contact with your loved one after they've exited the program or graduated it, and are they performing regular check-ins? These are key to find out.
Wow, we've covered a lot of ground, bio, psycho, social, and now let's finally get to that part of it that's very interesting to talk about with a medical doctor, and that's the spiritual aspect of treatment. I think many people may jump to the conclusion that that's not necessarily essential, and maybe they don't even know what that actually means. So maybe you could talk about it.
It's oftentimes in life the things we discard the most easily that are most important to us. Studies have shown that upwards of 84% of clients that are receiving treatment for substance use disorder wish there were treatment approaches integrated into the care plan with spirituality. And that speaks volumes. There's literally hundreds of studies out there that show the benefits of incorporating spirituality into the health treatment plan. And studies are particularly robust in addiction. We know right now roughly 3/4 of all treatment programs in America are including some degree of spirituality. So I think we in the treatment industry are recognizing the value of this, but we can certainly do better.
So let me ask, what do religious or spiritual practices offer in this area of substance abuse treatment?
How long you got, Kim? What's your watch say? I would say a ton for many clients. It's really addressing the existential questions that have haunted them and that will haunt them long after the drug use is, in a state of remission. It gives them purpose, Why get up in the morning? Oftentimes drugs were the alleviating factor for that sense of not having a purpose. It can offer community, a place to go when life gets tough, a shoulder to cry on. It often offers that restoration to people who feel broken and that sense of inner peace. And then it offers, in many cases, that sense of forgiveness, both for themselves and others. Remember, life has devolved for many of these people. There's guilt that comes with that, and the concept of sin can be a heavy burden on shoulders. This is one way to help address or alleviate that.
And as you said, this isn't just an opinion. This is based on studies. And what does the data show when people incorporate spirituality?
Yeah, it's a good question. People who are incorporating spirituality typically have improved treatment retention and reduced risk of relapse. There's been some great clinical studies on this. There was one that looked at 278 quantitative studies, and they found that 86% of those studies found that faith reduced the risks associated with alcohol use, abuse, or dependence. There was another one that looked at 185 quantitative studies, and 84% of those found that faith reduced the risk of drug abuse. So the data is out there. We just need to start incorporating on the care plan what the data is telling us to do.
So it seems like it's really important, and it's a really good idea to think about restoring the whole person as opposed to just parts that we see as broken. So do you see, or can you provide any other final thoughts on this topic?
Kim, we live in a divisive culture. We feel it every day, and I'm sad to say that we see a lot of that even within this industry. When someone's struggling with addiction, it's not uncommon to see different industries monopolize management of these conditions without necessarily referring someone or that patient out to other parts of the industry to manage the different domains. Examples would be doctors that are just offering, buprenorphine out of their clinics for opioid use disorder and not offering the references for psychology or social help that might be needed, or encouraging engagement in spiritual activities. Or, we also see psychologists that look at addiction and keep offering counseling session after counseling session. That person's going to relapse in the setting of opioid addiction in many cases unless they're started on the medications. So collaborate with the doctors, right? And then I've personally seen spiritual authorities offering nothing more than just prayer and a sense of community to people who are struggling with addiction when we recognize that there are truly biological drivers and mental health drivers for this disorder. This is not one-stop shopping when it comes to us living in our own individual communities, our own individual scientific domains, right? If we're not operating with a holistic model in mind for that person, we are setting them up for failure. So, Kim, if we're going to put the whole person back together, we need to work as a community, and I think we're recognizing that in our industries.
So again, this concept it's not just one thing. It's this entire biopsychosocial, spiritual aspect to it. And really, when you think about it, it's finding a way to get all of these different pieces of the puzzle working together and really looking at the person from a whole person standpoint and restoring them back to hopefully what they always wanted to be, and to not only to live, but to have a life.
You're absolutely right. The goal is recovery, and abstinence is going to be a part of that. But who would want a life of using no further drugs, right? And having no further relationships, right? Having no joy with recreation activities, no job, no sense of a purpose. They're set up for failure. Let's treat the whole person so they can live a full life.
Thank you again for being with us today.
Pleasure to be with you.